diabetes mellitus awareness month, we have wonderful cases of diabetic retinopathy. As you all know, it's a very, very important topic, not just for your examinations, but also for your clinical practice. So it is something that everyone should know. We have two cases that are going to be presented by one by Dr. Xavier Parmar from Pune, from Bharati Vidyapeeth, ably mentored by my dear friend Dr. Umang Gazarlewar, who's a visiting consultant there. And we have Dr. Sakshi Somani, who's a second year resident at TNMC in Mumbai, who's mentored by Dr. Naina Poddar, the professor and head, and of course Dr. Anuja Garat, additional professor at TNMC in Mumbai. Now, we are very privileged to have two extremely good examiners. One is Dr. Ajay Tamebar, who is professor and head at R.K. Damani Medical College and Hegdewar Hospital in Chhatrapati Sambhaji Nagar. And our national examiner is a man who needs no introduction. He is my teacher as well. When I was a resident and as a postgraduate student, I would roam around to different hospitals trying to learn and gather information. I met him and I learned from him at MM Zoshi Eye Hospital, where he was the head of department of retina. He's the director of clinical services and the head of VR services at MM Zoshi Eye Hospital in Hubli. It is my esteemed pleasure to welcome Dr. Guru Prasad Ayachit, sir. We have Dr. Preeti Kamdar also joining. So nice of you, madam, to come. She's the secretary of the Maharashtra Ophthalmic Society, a lovely teacher herself. And of course, the entire program is going to be moderated by Professor Archana Vare, who's the member scientific committee of MOS, as well as professor and head at Government Medical College in Chhatrapati Sambhaji Nagar. So with this outline, I would like to hand it over to Professor Vare. I will try to be there as much as possible. These are my favorite topics, diabetic retinopathy. However, I have a flight to catch, so I might not be there as actively participating in one of my favorite topics. So over to you, Vare, and to best of luck to both of you residents.
Okay, thank you. Thank you, Dr. Piyush. So we'll start with our first case that will be presented by Dr. Xavier Parmar, who is the junior resident at Bharati Vidyapeeth Deemed University Medical College, and he's mentored by Dr. Umang. So I request Dr. Xavier to share his screen and start presenting his case.
Yes, sir. Yes, ma'am. Is my screen visible?
You are audible and your screen is visible. You can go ahead.
So good evening, everyone. My name is Dr. Xavier Parmar. I'm a junior resident at Bharati Vidyapeeth, Pune. And my mentor for this case is Dr. Umang sir, who's a VR surgeon here at Bharati Vidyapeeth. So my patient is a 59-year-old diabetic female who presented to our OPD with chief complaints of gradual painless diminution of vision for both distance and near in the right eye since 1 year, with an associated distortion of images for near and a worsening of image in the last few months. So my patient was apparently all right 3 years ago, and she started to develop a diminution of vision in both eyes, which was gradual in onset, painless in nature, and progressive. After consulting an opthal for the same, the patient was diagnosed with cataract in both eyes, and she underwent cataract surgery in both eyes 2 years ago with good visual recovery as per the patient. Presently, the patient presented to us with complaints of gradual painless diminution of vision in the right eye since the past 1 year. And she also presented with a complaint of worsening of this vision in the last 1 to 2 months, which she also complained of a distortion of text while she was reading or doing any new work. She gives history of consulting an ophthalmologist for these similar complaints 6 months ago, for which the patient was told that she has some diabetic changes in her retina, and she was advised to undergo a retinal laser for the same. However, the patient was lost to follow-up. So the patient gives us no history of any spectacle use, no history of any flashes or floaters, no history of any ocular trauma. She denies any history of any retinal lasers or intravitreal injections that were given. The patient is a known case of diabetes mellitus since 20 years on oral medications, and which were poorly controlled as per the patient. However, the patient gives no history of any hypertension or any lipid disorders. On general examination, the patient was conscious, cooperative, and well-oriented, and her vitals were stable. On ocular examination, the uncorrected visual acuity for distance in the right eye was 6/60, which did not improve with a pinhole in the right eye. And for the left eye, it was 6/9, which did not improve with a pinhole. And for near vision, the patient read N36 in the right eye and N18 in the left eye. As the patient was complaining of distortion of images in her right eye, I did perform an Amsler's test for the patient. On occluding the left eye, she did complain that centrally the lines were bending inwards, which was suggestive of a central metamorphosis. The left eye, however, was absolutely normal. On anterior segment of both eyes, the conjunctiva of both eyes was normal. The cornea was normal in size, shape, color, sheen, and transparency. The anterior chamber was deep and it was quiet. The pupil was single central circular, reacting to both direct and concentric light reflex. The iris was normal in color and pattern. There was no evidence of any NVIs. And upon dilatation, the lens was found to be pseudophakic with a PCIOL in the bag. So on fundus examination, which was done with a 90 diopter lens and a 20D lens with using the IDEO, this is a fundus image of the right eye. So the media was found to be clear. However, in the posterior vitreous face, there was evidence of a white membrane-like sheet extending from the disc along the arcades, which was suggestive of a fibroproliferative vitreous band. The disc was normal in size, shape, and color with a 0.3 cup disc ratio and a healthy neuroretinal rim. And the vessels over the disc were normal. There were no evidence of any NVDs. The blood vessels were normal in course with evidence of slight venous dilatation. However, they were normal. There was no evidence of any looping or beading or any segmentation. In the background, there were evidence of multiple dot and blot hemorrhages that were seen in the mid-periphery. There was multiple areas of thin friable capillary network of vessels, which was suggestive of neovascularization elsewhere. And there were also evidence of multiple hard exudates. At the macula, there was a presence of a well-defined punched-out lesion that was seen at the fovea with the surrounding hypopigmentation. This was suggestive and suspicious of a macular hole. And there was also a presence of hard exudates in the surrounding macula. This is a fundus drawing for the same. The fundus image of the left eye, the media was found to be clear. There was, however, evidence of proliferative band present inferiorly extending from the disc. The disc was found to be normal in size, shape, and color with a 0.3 cup disc ratio and a healthy neuroretinal rim. And there was, once again, no evidence of any NVDs. The blood vessels were normal in course. Again, there was a slight venous dilatation that could be appreciated. However, there was no looping or beading. The background showed evidence of multiple dot and blot hemorrhages. And once again, there were capillary NVEs that were seen present temporally. At the macula, there was evidence of multiple hard exudates that were seen, and there was also a cotton wool spot that was present about half disc diameter away from the disc. This is a fundus image for this drawing for the same. The intraocular pressure that was measured on appellation tonometry at 2 p.m. was found to be 16 and 18 millimeters of mercury in both eyes. So with this, I came to a clinical diagnosis of both eyes proliferative diabetic retinopathy with a clinically significant macular edema and a suspicious squarey macular hole in the right eye, and the patient was bilaterally pseudophakic. So investigations that I would like to have carried out for this patient were blood investigations. A BSL fasting and a postprandial was done. An HbA1c, which was found to be slightly elevated, was 7.2%. Lipid
1
profile.
minute, doctor,
Yeah.
can I interrupt you?
Yes, sir.
You have to, at the end of your presentation of the history and clinical findings,
Yes,
you have
sir.
to summarize
Yes,
in one slide.
Okay.
To summarize in one slide as to what you are dealing with.
Yes.
And then you can go on to the next step, that is ancillary tests and
All right.
investigation.
Yes, sir. Yes, sir. So to summarize my case.
Again, sorry to interrupt, Dr. Xavier. Can you please switch on your video?
Yes, sir. Yes, sir. Sorry.
Yeah.
Yeah, am I visible?
Yeah. Again, share your screen.
Yeah. Is it visible, the screen?
Yeah, it is visible.
So to summarize my case, my patient is a 59-year-old diabetic female who presented to us with complaints of right eye gradual painless diminution of vision since the past 1 year, which worsened over the past 1 to 2 months with an associated distortion of images. And the patient was a known diabetic, poorly controlled on treatment. On ocular examination, the uncorrected visual acuity in the right eye was 6/60 and the left eye was 6/9. Both did not improve with a pinhole. And Amsler's was suggestive of a metamorphopsia centrally in the right eye. And on anterior segment, the patient was pseudophakic in both eyes. On fundus examination in the right eye, there was evidence of proliferative bands that were seen, along with multiple dot plot hemorrhages, microaneurysms, neovascularization elsewhere, hard exudates, and suspicious macular hole in the right eye. And in the left eye, there was evidence of proliferative bands inferiorly, along with multiple dot and plot hemorrhages, microaneurysms, hard exudates, and neovascularization elsewhere. So with this, I come to clinical diagnosis of a both eyes proliferative diabetic.
Before
Yes.
you come to the clinical diagnosis, Dr. Xavier,
Yes,
can we
sir.
go back to your picture, right eye picture, fundus picture?
Yes, sir.
So the drawing is a little disproportionate in the sense that here the fundus picture shows just up to the 45 degrees or 50 degrees is all that is seen, whereas you have drawn the fundus drawing up to the equator. And when you have examined the ora serrata up to the ora serrata only, you have to draw the ora serrata. Otherwise,
Yes.
don't draw the ora serrata if you have not seen it. If
All
you have
right.
done an indented examination, which we rarely do in vascular pathologies,
Yes.
for the fear of sudden decompression causing bleeding, we usually don't draw the ora serrata because we don't examine the ora to the periphery and we don't indent and see. So, and the proliferation that you've drawn, which is starting on the disc and along the arcades all around, that means along the superiotemporal arcade and infratemporal arcade, meeting at the horizontal raphe in a circular fashion. This is called grade 4 fibrovascular proliferation. And this is not depicted in our drawing. And in the drawing also, the green that you have shown should be broader.
Okay.
It looks linear, very thin, whereas in the picture that you are seeing on the fundus image is actually quite broad. So you have to make it proportionate to that. And you have to make the ends of this fibrous tissue meet at the horizontal raphe on the opposite side of the macula.
Yes.
So I think that is where the drawing is different from the fundus picture.
All right. Yes.
And
Yeah, I
everything has to be
agree.
labeled.
And
When you make a drawing, you have to label all the parts,
Okay.
all the findings. That is very, very important because green can stand for anything. Green can stand for vitreous hemorrhage, can stand for fibrous tissue, can stand for foreign body, can stand for anything in the vitreous cavity is green. In fact, anything that is subretinal also is green. Therefore, I think you have to label what you have drawn.
Yes. Yes.
Yeah.
and also you have not drawn the
Can you please stop sharing your screen, Dr. Xavier?
Yes. Yes.
Hello.
Yeah. I request Tameva sir to ask him the questions, please.
Yeah, and so in the drawing, retinal drawing, you have not drawn the neovascularization NVE, NVD. So just only the glial membranes in the green color you have drawn, but you have not shown the NVEs or NVDs in the drawing. So will you show the NVE, flat NVE and elevated NVE in the drawing? What color?
NVEs I had drawn with a red color in the
Flat and elevated NVE. There is a difference. How will you show that? Flat NVE by which color and elevated NVE?
flat NVE would have been with a red color in a coil-like pattern, whereas an elevated would have been with a green, since it would have been more in the vitreous.
No, actually both are shown by the red color only, but the margin outline of flat will be blue color, and whereas outline of elevated NVE will be green color. So there is a significance. What does it indicate? Whether when it is a flat NVE and or elevated NVE, what is the significance of differentiating between these two? Why you want to know whether it is a flat NVE or elevated NVE? Does the treatment option
Treatment would differ. So in case of a flat NV, we could plan for a PRP laser primarily and then observe. Whereas if there was an elevated NV, then maybe we would have to look for if there's any traction component involved, if any surgical intervention needs to be
Right.
planned.
So that indicates the traction. So you have to start the treatment, advise the treatment immediately. So it is a chance of bleeding and complications when there is an elevated NV indicating the traction, as you rightly said. So that is why it is essential. Okay. Also, when you are describing, you are directly telling that there are hemorrhages, exudates, either hard exudates or paternal spots. Actually, you should be describing the findings first, what is the appearance, and then you have to tell suggestive of hard exudates. Suppose there are yellow dots, so it can be drusen, it can be hard exudates. So how will you differentiate between drusen and hard exudates?
So one that if it was a hard exudate, you would also have an associated, there would be more hemorrhages and that kind of a picture in case of a diabetic retinopathy. Whereas in case of drusens, they're yellowish to whitish color with slight, the margins are not as well defined as in case of hard exudate. And
Is there any difference in the depth of the
the depth
drusen?
also, drusens would be seen at the RP level, sub RP level, whereas in case of hard exudate would be seen around the out of lexiform level. So
Okay.
inner retinal layers.
So they are deeper than the blood vessels.
Yes.
Drusen are deeper, whereas
Drusens would be
they are
deeper.
at the level of the blood vessels.
Yes.
Okay, so you have to describe. Similarly, the hemorrhages, you have to, even NVE, you have to describe the clinical appearance and then you can say that suggestive of NVE or
Yes.
suggestive of NVD. So can describe a loop of capillaries or the new vessels on the surface of the retina or entering into the vitreous cavity or on the surface of the disc. That is how you have to describe it first and then say that suggestive of NVE or NVD. Okay.
Yes.
In the history, have you asked about the diabetes control? Means what was whether it was well controlled, poorly controlled, or there are fluctuations in the blood sugar levels?
So as per the patient, like in the last 1 year, the sugars were well
What is
controlled.
its
But
significance? What is the significance of asking this
uh,
history?
if there is a fluctuation of blood sugars, whether it's too high or too low, that can also, if there's a large fluctuation of sugars, that can further worsen the progression of diabetic retinopathy.
Yeah, progression is fast and
And
complications are also. So that is why it is important to know the glycemic status. Also, which oral hypoglycemic agents? Is it significant? You have to ask whether patient is on glitazones. Okay, why it is important? What is the significance?
not aware.
Patients who are on glitazones, they are more prone for macular edema as compared to other hypoglycemic agents. So you have to consult with your diabetologist or ask them that glitazones should be avoided. Patients who are having center involved macular edema or the DME.
Okay.
So another thing is that again, you have to ask when patient has simultaneous hypertension, you should ask the patient to avoid the nocturnal hypotension. So the hypertensive agents, so that also you have to look into that because hypoxia, nocturnal hypotension leads to the hypoxia of the choroidal vessels and the retinal blood vessels, leading to the more progression of the diabetic retinopathy and also the maculopathy. So that factor also the lipid control. So all these things you have to, in your systemic history, you have to ask to the patient in detail.
Yes.
I request Ayachit sir also to ask questions to Dr. Xavier.
Yeah. Actually, I had started asking, but I thought I should wait for Dr. Archana's cue to. No problem. Yeah. This is a very good case from the examination point of view because this is the kind of case that will be kept in the exam. When you are confronted with a case where there is a combined fibrovascular proliferation and diabetic macular edema, in the sense that there are hard exudates in the posterior pole, which always does not mean that there is macular edema. Hard exudates does not always commensurate with the existence of macular edema, because hard exudates can be the residue, just the residue without edema. So one has to examine with 90D and confirm the presence of thickening, or best is to resort to ancillary tests like OCT to know whether there is macular edema or not. If you are having a coexisting proliferative diabetic retinopathy with macular edema, then the treatment will slightly differ as compared to just proliferative diabetic retinopathy. What was the finding in the left eye which made you feel that it is a PDR? You said there is PDR both eyes. In the left eye, did you describe NVEs anywhere? NVEs were they present?
Yes,
Dr.
sir.
Xavier?
Yes, so along the superior temporal quadrant, there were 2 to 3 areas where there was a new the friable network of vessels could be appreciated, which was suggestive of new vascularization. Yes.
Right. One more thing about this presentation of such cases is that you have to mention whether the pupil dilates well or not.
Yes.
Because the treatment is going to depend on whether you're able to have a dilated pupil for treatment of the retina. So sometimes the pupils in diabetics do not dilate well because of various reasons. They have a rigid pupil because of glycogen deposition in the iris, because of autonomic neuropathy, and so on. So therefore, you have to mention whether the pupil is dilating fully or not. If you want to do a laser treatment, for example, you should have a well dilated pupil, isn't it? So can you again summarize or tell the diagnosis of each eye separately?
Yes, sir.
You can start off with being the eye being pseudophakic. It's a pseudophakia with
Yes. So the right eye is a pseudophakic eye with proliferative diabetic retinopathy, with a right eye macular hole, with a clinically significant macular edema. However, on doing an OCT, the macular edema was not found to be as significant. So
clinically significant macular edema you diagnose based on the presence of hard
based on
exudates
the
close to
yes,
but
yes,
was there thickening on 90D examination? That is my question.
sir, to me, I felt like there was on the 90
You mean it's a subjective test? CSME as per the ATTRS is a subjective test because each one can make a different
Yes.
interpretation of the thickness.
Yes.
So whether there was actual thickness and what is CSME is one question that they will definitely ask.
Yes.
So can you tell the 3 criteria which fits into the diagnosis of CSME?
So the first criteria is any retinal thickening that is present within 500 microns of the center of the macula. Then the second criteria is hard exudates that are present within 500 microns of the center of the macula. And the third criteria is any retinal thickening.
No. Second criteria is with adjacent
retinal thickening.
Right.
Yes. And
the third
criteria is any retinal thickening that is of greater than 1 disc diameter size, any part of which is within 1 disc diameter of the center of the macula.
Right.
Right.
It's not just retinal thickening, hard exudate ring. A hard exudate ring, 1 disc diameter in diameter, any part of which is within 1 disc diameter from the center of the fovea.
Yes.
So that is the third criteria for to diagnose CSME.
Yes.
Okay. Any other classification of diabetic macular edema you know?
Sir, on the basis of OCT, there is a classification where grade 1 is focal macular edema. Then grade 2 is a diffuse non-cystoid macular edema. Grade 3 is a diffuse cystoid macular edema.
It's not grade, it is a type.
It is
type.
There are different types. There is no grading in OCT-based classification. And I think most important is center involving and non-center involving. For practical purposes, to treat the patient, what you need to know is whether it is center involving or non-center involving.
Okay.
But the 5 characteristics of macular edema on OCT, you have to mention. One is spongy edema, cystoid edema, subfoveal fluid, taut posterior hyaloid, and VMT. These are the 5 types of macular edema as seen on the OCT. I think this you have to remember and rattle it out in the examination when they ask this.
Yes.
So the reason why you have to differentiate between center involving and non-center involving again is because the treatment of these two will be different.
Yes.
So in this particular patient, how are you going to help the patient? The patient has come to you. So how are you going to help the patient?
First for the left eye, since it is just a PDR on there was just not neovascularization. There was no VMT. There was no the retina was attached otherwise. So for the left eye, PRP laser should be planned.
Now, have you done an OCT in this
Yes, sir. I
patient?
have done an OCT for this patient.
What
I
does
have.
OCT say?
So the OCT of the right eye, there was the foveal contour was distorted due to the an interruption in the continuity because of a presence of a full thickness macular hole, which also showed subretinal fluid collection.
Have you the OCT in one of the slides?
Yes, sir. I have the
You have the
OCT.
OCT.
Yes,
Can
I'll
you
share. Yes, yes.
show it to me?
Yes.
There is so much of fibroscular proliferation. Is there any TRD along the fibroscular proliferation?
No, so there was no TRD
No
in
TRD.
anthropoids. Yes, sir.
That means the fibrous tissue was just adherent to the retina and not pulling the retina.
Yes, sir.
Okay. So this is the OCT. Okay. So there is a full thickness macular hole with. Is there anything else?
Sir, there was subretinal fluid that was also present,
Right.
and on the left side, you could also see the traction, the proliferative band that was present.
In the left eye, there is no traction. It is just a
No
VMA.
traction. Yes, sir.
It's I'm not able to see it very clearly because it is
We can
magnified.
zoom in.
It's a small image. If you can make it bigger, maybe we can see it better. But then what I surmise from this image is that it is just a vitromacular adhesion and there's no
Yes.
actual pull on the structure. There are no morphological changes in the retina, which
Yes.
does not qualify to be called as vitromacular traction.
Yes.
It is just a vitromacular adhesion.
Yes.
You need not do anything to the left eye in terms of treatment for the macula. All that you need to do is treatment of the proliferative diabetic retinopathy
Yes.
with
PRP lasers.
PRP. How do you do the PRP?
Sir, it has been done in preferably in 3 settings with the power of about 200 milliwatts and interval of 0.01 milliseconds and the gap of 2 burn spots between each.
No, I think what is more important when you do a laser treatment is to get a grade 3 to 4, maximum 4, but then try to keep it at grade 3. Grade 3 reaction of 200 microns each, which does not spread much and cause inflammation. So that is the criteria. The parameters that you need may depend on, in this eye, it's a pseudophakic eye. Dr. Archana, you can stop me and Dr. Ajay can take over any time, but let me complete this particular part.
Yes, sir.
The media is very important. If the patient has nuclear sclerosis, especially if it is grade 2 or grade 3 nuclear sclerosis, then the patient will need a higher power, maybe longer duration to get a desired reaction on the retina. Whereas a pseudophakic eye or a younger patient with a clear lens does not need a heavy reaction or does not need a high power or a longer duration of energy to get a desired reaction. So what you have to aim is to get a grade 3 reaction of 200 microns in size, which is grade 3. Okay, and one burn width apart.
One burn.
Not 2 burns width apart. One burn width apart.
Yes.
And which part of the retina do you treat? When you say pan-retinal photocoagulation, the word indicates that pan-retinal means the entire retina. So do you treat the entire retina or do you spare some region?
So sparing the sparing the like 500 microns away from the disc, and of course sparing the macular region as well.
How far away from the macula would you treat? temporarily. Okay, above and below you will treat above and below the arcades, right?
Yes, sir.
You will there also will probably leave in the beginning 1 disc diameter of zone of clear untreated retina and treat the remaining peripheral retina, mid periphery and up to the far periphery to the extent possible. But temporarily, where will you stop? Where will you stop and not come in closer to the macula? Which zone or how many disc diameters from the center of the fovea?
Not sure about that, sir.
Have you done a laser treatment? Have you seen it being done? Have you
Yes, sir.
seen a treated patient?
Yes, sir.
So how far from the center of the fovea does the temporal set of laser burns? Where are they placed? So it's about 3 disc diameters. 3 disc diameters from the center of the fovea temporarily. You draw a line there to sort of make a Lakshman Rekha and not to enter inside that. Okay, and always treat the area outside that line.
Yes.
And then that is a sort of safety for you not to enter inside, okay, and not to treat the fovea inadvertently.
Yes.
And then treat the rest of the retina once burn width apart with one burn width apart burns up to the far periphery as to the extent possible. Sometimes with LIO, that is laser indirect orthoscope, you're able to treat up to the ora serrata by indentation. Indentation we go.
That's it, sir. You are like you are a very good teacher also. I mean, less of an examiner and more of a teacher. But sir, now it's time to move ahead to our second.
Yes. No, that's what I told you to stop me whenever you feel that there is no, I'm talking too much.
No, sir. Sir, our next presenter is Dr. Sakshi. She is the second-year resident at Nair Hospital, Mumbai, and she is mentored by Dr. Anuja and Dr. Naina Poddar, ma'am. So over to you, Sakshi. Please start sharing your screen.
Dr. Ajay, you please examine this, Dr. Sakshi. I will keep quiet and only on the request of Dr. Archana I will come in.
No, sir. Both of you have to. I mean, it's not like Dr. Sakshi. Please keep your video on.
Just a minute, ma'am. Am I audible?
Yeah, you're audible. Your slides are visible. Just make it full screen and keep your video on.
Is my video on now?
Yeah.
So, good evening. I'll first, at the outset, I'd like to thank Mos for giving me this opportunity. I am Dr. Sakshi JR2 from Nair Hospital, and I'm going to present a case of a 55-year-old male resident of Andheri, laborer by occupation, who came to us with complaint of diminution of vision in both eyes since 6 months. Patient was apparently all right 6 months back when he started complaining of gradual, painless, progressive diminution of vision in both eyes, more in left than right eye. Patient had no history of redness, photophobia, or watering, no history of flashes or floaters, no history of spectacle use, no history of use of any topical medications, no history of trauma, laser, intravitreal injection, or any ocular surgery, no history of headache. Patient was a known case of diabetes mellitus since 6 years on oral hypoglycemic agents but not compliant to them. Patient had no history of hypertension, CVA, or IHD. Family and past history was not significant. Patient was on mixed diet, sleep, bowel, and bladder habits were normal, and patient denied any addiction. On general and systemic examination, all the parameters were within normal limits. Now coming to the ocular examination, the head posture and facial symmetry was maintained. On Hirschberg reflex test, patient was orthophoric. On examination of the vision in right eye, for distance, the vision was 3/60, not improving with pinhole, and in the left eye, the distance vision was 1/60, not improving with pinhole. The near vision in both the eyes was less than n/36. On measurement of intraocular pressure by non-contact tonometry, the pressure in the right eye was 17 millimeters of mercury and in the left eye 19 millimeters of mercury. Extraocular movements were full and free in all the 9 cases. On anterior segment examination, lids and adnexa were normal in both eyes, conjunctiva was normal, cornea was clear, anterior chamber was of normal depth in both eyes, iris had brown color and normal pattern, no evidence of neovascularization noted. The pupil was 3 mm in size, round and reactive to light, and there was no evidence of RAPD in the left eye. The cataractus grade was nucleus sclerosis 1 in both eyes. Now, fundus examination was done with direct ophthalmoscopy, indirect ophthalmoscopy, and slit lamp microscopy 90D. The media was found to be clear. The optic disc was round in shape, pink in color, with a 0.4 CDR and a healthy neuroretinal rim. The blood vessels were arising from the center of the disc, diacomatously branching with an arteriovenous ratio of 2:3. Venous tortuosity was noted in a vein in the superiotemporal quadrant. On the macular examination, presence of fine yellow discrete lesions were noted that was suggestive of hard exudate. Presence of pinhead-shaped red lesions were noted, suggestive of microaneurysms. Presence of hard exudate were also noted in the inferonasal quadrant, and dot blood hemorrhages were found scattered in the peripheral fundus. On the examination of the left eye, the media was clear, optic disc was of 0.3 CDR, round in shape, pink in color, and with a healthy neuroretinal rim. Vessels were starting from the center of the disc, diachomatously branching with an arteriovenous ratio of 2:3. Again, on the macular examination, presence of fine, discrete yellow lesions were noted, few scattered and few clumped together, suggestive of hard exudates, along with dot blot-shaped red lesions suggestive of dot blot hemorrhages and pinhead-shaped red lesions suggestive of microaneurysms. Peripheral fundus examination showed presence of dot blot hemorrhages scattered all around. This is the Amsler-Dubois chart. Now OCT macula was done, and in the right eye, presence of hyperreflective dots was found in the outer retinal layers, and the retinal thickness was 234 micrometers.
Please.
Yes, sir.
Yeah, before investigation, just what is your diagnosis?
Yes, sir. So my diagnosis is of right eye, moderate non-proliferative diabetic retinopathy with grade 1 nuclear sclerosis, and in the left eye, moderate non-proliferative diabetic retinopathy with clinically significant macular edema with grade 1 nuclear sclerosis.
What about your right eye macula? You said
Sorry, sir?
right eye macula? There was no macular DME in right eye?
No, sir. On 90D examination, I could not note any retinal thickness. So only
But
hard
there are hard
exudates were.
exudates.
Yes, sir, but adjacent retinal thickening was not noted, so we cannot.
There is a difference between CSME and DME.
Okay, sir.
DME is different, CSME is different. Retinal thickening and hard exudates it requires for CSME.
Okay, sir.
DME is different. So it is a whole macular area. When we get hard exudates or anything abnormal in the macula, that is DME, diabetic macular edema. CSME is different. So clinically significant is different and only DME is different. When there are hard exudates, vascular abnormalities, aneurysms or hemorrhages in the macula, it indicates it is a maculopathy.
Yes, sir.
So CSME is different. Thickening, then when you have these criteria, three criteria of CSME, then you can label it as a CSME. But this patient, if you see the macula, there is clear-cut DME.
Okay, sir. Yes, sir.
So your diagnosis should be, you should include in right eye, both eye has the diabetic macular edema. It may or may not be CSME, or now it should be center involving
Sir.
macular edema or non-center involving macular edema.
Yes, sir. Should I continue?
Yeah, please continue.
And you have to mention that there is associated retinal thickening in macula, whether it is there or not, if you can appreciate on slit lamp biomicroscopy. So it is important.
Yes, sir.
Okay, so your full diagnosis now is corrected diagnosis?
So my corrected diagnosis is presence of moderate non-proliferative diabetic retinopathy with diabetic macular edema in the right eye with nuclear sclerosis grade 1, and in the left eye, moderate proliferative diabetic retinopathy with clinically significant macular edema with grade 1 nuclear sclerosis.
Okay. Now you can proceed with what will you do? How will you manage?
So no need to share the investigations, or should I directly proceed to the management?
Okay, investigations.
So I did OCT macula for this patient, and in the right eye, presence of hyperreflective dots were noted in the outer retinal layer suggestive of hard exudates, and retinal thickness was noted to be 234 micrometers at the center of macula. In the left eye, retinal thickness was noted to be 523 micrometers at the center of macula. Foveal counter was lost. Hard hyperreflective dots were noted in the outer layer of the retina, suggestive of hard exudates. Cystic spaces were noted in the inner and outer layer of the retina. And fluid was noted between the neurosensory retina and the retinal pigment epithelium, suggestive of subretinal fluid. OCT angiography was done.
Why you label as hard exudates?
So
What is
because
the,
of
how
the
will you differentiate between hyperreflective retinal foci and the hard exudates in OCT?
so in the depending on the layer of the lesion.
Hyperreflective retinal foci can present in any layer. They can starting from even choroid up to the superficial layers. They can present in even there, so that is why they are labeled as hyperreflective retinal foci and hyperreflective choroidal foci. Both are there. So how will you differentiate it from hard exudates? Because they look like same. The appearance is similar on OCT. What are the differentiating features of hard exudates? And it is important. Why it is important to know the whether hyperreflective foci are present or not? What is the significance of knowing HRF, presence of HRF?
So no idea.
It is one of the important OCT biomarker of
Okay, so
diabetic macular
for
edema.
prognostication.
Yeah, prognostication, and important thing is not only the prognostication. Another significance of hyperreflective foci is treatment choice. You have to decide the treatment depending on this presence or absence of biomarkers, OCT biomarkers. What are other OCT biomarkers?
So we will look for drill disorganization of retinal layers,
Okay.
outer retinal
Disorganization of
tubulations,
retinal inner layers. Second
outer
is,
retinal tubulations,
okay.
ORT.
What else? Okay, what
Uh,
else?
so I know these two.
You have shown here the presence of subfoveal subretinal fluid.
Yes, sir. Subretinal fluid. Yeah, obviously, sir.
That is also one of the marker.
Yes, sir.
Then presence or absence of cystic spaces, large intraretinal cysts. Is it a biomarker?
Yes, sir.
Yeah. So then another thing is disruption of the ellipsoid zone.
Yes, sir.
So these are all OCT biomarkers. So why you want to look after look for these biomarkers? One is you said prognosis, and another important thing is treatment choice.
Treatment options.
Do you know what are the causes of this hyperreflective foci, retinal foci? Are you seeing? What is the
No, sir.
pathophysiology of this HRF?
No, sir. I haven't.
These are you see why you want to differentiate between hard exudates and HRF is because the etiology is different. Hard exudates is nothing but the lipid deposition into the substance of the retina or in the retinal layers, whereas HRFs indicates the microglial activations or the disrupted photoreceptor accumulation of the photoreceptor segments within the retina, or they are the RP cells, degenerated RPE cells. And these are important inflammatory biomarkers of the retina. So it indicates inflammation-driven macular edema as compared to the ischemia-driven macular edema or CSME or DME. So that is why the treatment choice depends upon whether there is predominantly which biomarker is predominant and the prognosis also. The treatment option, whether to go for anti-VEGF treatment or intravitreal or steroid implants, depending on that, you can decide the treatment and response to the treatment. So that is why the importance of all these biomarkers is there. Also, these biomarkers helps in deciding the response to the therapy, whether what is the response, whether they are responding well to the anti-VEGF treatments or intravitreal steroids. So you can monitor the response to the treatment depending on this biomarker. So that is why these biomarkers are very important. Okay, go
Yes, sir.
ahead.
OCT angiography was done, and in the right eye, foveal avascular zone was noted to be enlarged, suggestive of macular ischemia. And in the left eye, there was diffuse leak present along with enlarged foveal avascular zone. So we ordered few blood investigations for the patient. CBC, RFT, and serum electrolytes were normal. FBS and PPBS were raised along with
What is
HbA1c.
the what is the advantage of OCTA over OCT?
So we
Would you
can,
given a choice, would you prefer OCT or OCTA?
so both have their own advantages. For OCTA, we can know the condition of blood vessels without injecting any fluorescing substance in his body,
It is
and
non-invasive.
non-invasive, yes.
Yeah.
So
What are
OCTA will,
OCTA octa biomarkers for DME? What are the OCTA biomarkers? We have seen OCT biomarkers. What are OCTA biomarkers? What will you look for
so I
in
will
OCT?
look for the foveal avascular zone. How are the what is how much leakage is there, if there is diffuse leak present or focal leak is present, and
No,
in
no,
which
you
layer.
cannot see the leakage in OCTA. Not you cannot see the leakage. That is the drawback of OCTA or octa. Leakage is seen in FFA, not in octa. A
So
foveal avascular zone,
hyperfluorescence.
right? So size of the foveal avascular zone, area of the foveal avascular zone. What else? Another important biomarker, OCTA.
Capillary
Because all
non-perfusion
this, why
areas.
it is important? Because there is a you can assess the diabetic macular edema both quantitatively as well as qualitatively with OCTA. So you can diagnose, not only diagnosis, but also you can quantitate the findings, and that is why these biomarkers, so the knowing the area of foveal vascular zone, regularity of the foveal vascular zone, presence or absence of the capillary dropout areas in the both the plexuses, superficial capillary plexus and deep capillary plexus. So all these are important. So you can quantify, and also the qualitatively you can decide whether this DME will respond to the treatment or what is the prognosis, and you can also monitor the response to the treatment. Okay. There are other
Yes, sir.
biomarkers also, so vascular density index, vascular diameter index, capillary density index. So all these biomarkers, OCTA biomarkers are important to measure quantitatively and prognosticate decide the treatment of DME. Okay,
Yes,
go
sir.
ahead. How will you treat this case?
So for treatment, first we will advise strict optimization of systemic conditions. Suggest him. Sorry, ma'am.
Sakshi, you can stop sharing. I mean, are you done with the your
Yes,
presentation?
ma'am. Last slide. Yes, ma'am.
So you can stop sharing your screen. And please switch on your camera.
Ma'am, my camera is switched on.
No, we can't see you.
Okay. Now am I visible?
No, you're not. Stop sharing your screen first.
Yeah, ma'am, I've stopped sharing my screen.
Okay.
I think her video may not be on.
Okay. Okay. Ayachit sir, would you like to ask a questions?
Well, I think we'll continue with what Dr. K stopped at. So how will you go about treating this patient? This patient has come to you with diabetic macular edema and loss of vision. So you said you will treat the systemic condition. So it's a co-management. It's
Yes,
not
sir.
something that you will wait for the diabetes to get controlled or the hypertension to get controlled. By then the edema can become worse. So you will co-manage, meaning the physician will treat his part and you will treat the ophthalmic part. Okay. So the ophthalmic part, how will you treat?
So for ophthalmic part, for his left eye, we will consider giving him anti-VEGF injections. For the right eye, at present, since his OCTA is suggestive of macular ischemia, for now we will not treat it and explain poor prognostic signs for his right eye.
Why not treatment for the left eye? You have
So
to
for
treat the
the
left eye that is suffering even more than the right eye, isn't it? You have to treat both eyes. So first of all, what the question will arise: what are the various pharmacotherapeutic agents that are available for you to give in your armamentarium to give as an injection in the eye, or what are the modalities of treatment that you can offer to the patient?
so we can
So,
give him we have anti-VEGF injection, we have intravitreal steroids, and we have focal or grid laser options.
hmm. So,
Uh,
sir was asking about the choice of treatment. So, how will you choose the treatment? How will you choose? There are so many anti-VEGFs. Can you name the anti-VEGFs?
yes, sir. We have ranibizumab, we have aflibercept, we have bevacizumab, brolucizumab, faricizumab.
Faricimab.
Yes, sir.
No, don't make that mistake. It is faricimab.
Faricimab.
Verisima.
Sorry, sir.
It is not faricimab. It is faricimab. Okay. Yeah. And then,
Yes, sir.
so, all
And
right.
for
So, these are the various anti-VEGFs that are available. Aflibercept is slightly different in that it is a VEGF trap, and
yes, sir.
you have steroids in the form of triamcinolone, which is usually not used very frequently, but dex implant is more frequently used.
Ozurdex.
So how will you choose between these two, looking at the patient as a whole and the patient's OCT? Sir has already given you hints about the choice of treatment based on the
So
OCT.
yes,
Hmm.
sir. We will go ahead with anti-VEGF injection for this patient because hard exudates are present. That means hypoxic changes have set in, and
One thing I would like
vascular
to add to Dr.
permeability.
Ajay's comments on hyperrefractive spots and hard exudates, how to differentiate. Hyperrefractive spots are usually 30 microns or less. 30 microns or less,
Okay.
and they do not cause shadowing, and they are discrete. The OCT will not show any shadowing. Whereas hard exudates are more clumpy, they are bigger, okay, and they cause shadowing. So that's the difference between the two. The hyperreflectivity of both are slightly different. Hyperreflectivity of the HR hyperreflective spots or the foci and the hard exudates are different. And like Dr. Ajay already said, they are activated microglial cells which are an indication that it could be of inflammatory origin. And there is evidence to say that there is release of cytokines and interleukins. IL-6 and IL-12 are released, as a result of which steroids probably would work better in patients with HRF. Not
Yes.
only HRF is one of the biomarkers. The other biomarkers also he has told. This, in fact, the left eye of this patient has NSD. NSD is the
Yes, sir.
subretinal fluid that he was talking about, and drill. There is drill also. So the presence of drill, presence of NSD, presence of hard exudates, all these are inflammatory biomarkers which warrant the need for steroids
Steroids.
rather than anti-VEGFs. The other indication for or the other parameter that you would like to look at to treat with steroids or anti-VEGF would depend on the background retinopathy. If the background retinopathy has reached a stage where it is moderate to severe NPDR and which is likely to move over or cross over to the PDR stage, then I think steroids should be withheld and anti-VEGF should be given, because anti-VEGFs are known to downscale the severity of uh, the diabetic retinopathy. From severe PDR, it can come down to moderate PDR. So from severe NPDR, it can come down to moderate NPDR. So I think that is advantage of anti-VEGFs over steroids when it comes to treating background retinopathy, which is very severe, which is very advanced. So this is the way you have to answer in the exam about the choice of anti-VEGFs or steroids. How to select between the two. Okay.
Yes,
So,
sir.
what is the duration of action of each of these anti-VEGFs that you talked about? You already said there are so many anti-VEGFs. So, what is the duration of action?
Ranibizumab and bevacizumab last for a month. Aflibercept 2 monthly. We have to repeat the injection. First, we have to give 3 monthly injections, and then we can repeat it 2 monthly. For brolucizumab, we can give 3 monthly injections, and for faricimab, 4 monthly injection can be given. Ozurdex implant lasts for 6 months. and another option of
No,
fluocinol acetate.
actually, Ozurdex, Dex implants. You're talking about Dex implants, is it? Or
Yes, sir.
fluocinol?
Ozurdex. Yeah.
Dex implants, no, they don't last for 6 months. They last for about 3 months at the most. They claim in the Geneva trial, it is claimed that they work for 6 months, but actually it is not so. We
Okay.
have our own real world experience says that it works only for 3 months. Dr. Ajay
Oh,
will
okay,
agree
sir.
with me.
Yeah,
Um,
sure.
yeah. So I think don't say 6 months. 6 months is only in the books, and that too in the older studies. Recent studies have shown that it doesn't work for more than 3 months. Uh,
Okay, sir.
so, so there's no drug which can work for more than 4 months. But however, there are certain treatment protocols or intervals where after the initial treatment by which you can stabilize the disease, reduce the macular edema to a considerable degree. You can go to a protocol called treat and extend.
Yes,
I
sir.
think this is a little too much for the PGs. At the fellowship level, I think we need to understand all this. But then it is good to know that
Yes, sir.
there is a protocol called PRN. There's a protocol called TREX or treat and extend, wherein you go on increasing the interval after the stabilization of the disease. Maybe after 6 months of treatment with 2 monthly, maximum 3 month injections, you can increase the interval to even 4 months, 16 weeks with the
Yes, sir.
help of with prolicizumab and sometimes with Eylea as well, that is aflibercept as well. So with these two, you are able to increase the interval to 16 weeks, and the 16 weeks is the maximum that you can achieve. And every 16 weeks, an injection has to be given. And unfortunately, these injections are expensive, and these injections have to be given lifelong, almost
Yes, sir.
lifelong. So the patients usually take the injections till they get bored, and you get bored of giving the injections. So it is like that. Okay. So you don't tell like this in the exam. You have to tell that the patient will need injections for a very
No,
long period of time.
long time. Yes, sir.
Right.
Hello, Dr.
Yes, sir.
Archana, can I ask?
Yes, sir. Yes, sir. We still have time. Yeah.
Yeah, so Sakshi, suppose this patient, you said the patient has NS grade 1,
Yes, sir.
okay, both eyes.
Yes, sir.
Suppose this patient had NS grade 2 to 3 or treatable cataract or warranting the cataract treatment. So cataract associated with diabetic macular edema. So which will you treat first, cataract or diabetic macular edema?
So diabetic macular edema, definitely. Because
Why?
cataract itself has a complication of causing macular edema. Cataract surgery has a complication of causing macular edema, and in a diabetic case, the risk increases. So first we
But
will treat
suppose it
him.
is NS grade 3 or more than that, or then the imaging will be difficult, or monitoring the treatment response and monitoring the progression of the DME is difficult. So, can you
So
do
in
both
that
at the
case,
same time, cataract extraction
yes,
along
sir,
with
we can combine the two.
intravitreal injection of?
Yes, sir, we can combine the two. If that is the grade that the posterior pole is not being visualized properly, or as you said, so we can combine the two, cataract surgery with intravitreal injection.
Okay, if patient has non-clinically significant or mild DME or non-center involving DME, what is the chance or when patient develops or progression of DME after cataract surgery? Till what period you will observe or you will follow up the patient? Till what period there is a risk of progression of DME after cataract surgery?
So I'm not sure about this.
So up to 2 months. It's up
Okay.
to 2 months. Okay. You have to ask the patient for frequent follow-up and monitor the patients. You can repeat the OCT and see the progression or worsening of the diabetic retinopathy or DME. So why DME increases after cataract surgery? What is the reason for progression of DME?
So cataract surgery causes inflammation, will increase inflammation of the eye, and that's why it will increase the macular edema.
Okay. Right.
So,
So it's inflammatory response, and inflammatory cytokines are released after cataract surgery, and that may increase or progression of the lead to the progression of DME. So that is why this patient should be warned, and they should be counseled accordingly that the vision improvement may not be good, because every patient now after cataract surgery they feel that they should have 6/6 vision, so their expectations are now very high. So you have to counsel the patient accordingly, because there may be progression of the DME. In fact, the vision may drop after the cataract surgery because of the progression. So that you have to counsel to the patient.
Yes, sir.
Okay.
yeah, so with this, we come towards the end of the webinar, and I just wanted comments from Dr. Anuja and Dr. Umang. So, Dr. Anuja, Naina ma'am, are you there?
She's there, but video is not on.
Dr. Anuja? Yeah.
Yeah, good evening, everyone. It was a really nice discussion and case presentation by both the students. I feel really grateful for being part of this wonderful Mos PG case presentation program. Actually, I would actually like to appreciate Sakshi's courage to come forward at very short notice, because she was replaced in place
Yes,
of third year resident.
yes,
She
yes.
could
She had
not
very
appear. Yeah.
yeah, she just had a week or so, but she prepared very well. Yeah, that's true.
And I also learned a lot from the experts. Yeah. It was a great learning for me also. Thank you. Thank you, everyone.
Umang sir?
Good evening, all. I think both presentations were good, but I think overall, we also have to learn a lot from the examiners, I guess. Thank you, sir. Thank you very much.
And with this,
Yeah, both have presented nicely. Both the case presentations were good, nice.
thank you, sir.
Absolutely. Those were good.
And with this, I request Dr. Preeti Kamdar, she is the Secretary of Maharashtra Ophthalmological Society, to give the vote of thanks and her concluding remarks as well.
It was an hour very well spent, and with a lot of very precise clinical nuggets, which even the students will appreciate, but we are going to take it home and include it in our practice. So thank you for that, sir. On behalf of the MOS, let me begin by thanking the youngest members, Dr. Xavier and Dr. Sakshi. It requires courage to present in front of an unfamiliar audience. So that's a great feat. And
Thank you, ma'am.
it's not easy to mentor. And the mentors, Dr. Umang and Dr. Umang Gajarlewal, Dr. Naina Poddar, Dr. Anuja, have done a wonderful job training our young ophthalmologists. It's not an easy job, it's a big responsibility. And Dr. Ayachit sir and Dr. Ajay Tamewar sir, they were such amazing examiners. They were teaching and questioning at the same time. It's not very easy, and being gentle in their demeanor. It's not that everybody can do that. So thank you very much, both of you, for sparing your time and enlightening all of us. And Dr. Archana Vare, she's the strength behind our monthly PG programs. And I'm grateful to her for all the hard work she puts in crafting these wonderful sessions. So I thank you. And I thank also Numeratech for providing the digital support for a seamless webinar. And I wish you all a very good night. And till we meet again, goodbye to all of you. Yeah.
Thank you. Thank you.
Okay.
Thank you.
Bye. Bye.
Thank you, ma'am.
Bye.
Thank you.
Good. Bye.